and you will see the aortography with the valve is calcified. There is no ventricular regurgitation. Next. The ilioaccess femoral is good. Next. You see, it's wide, it's straight, it's not calcified. Suivant. Of course, as we do systematically in the screening, we did CT scan. In the CT scan, the valve area is almost 400 and perimeter is 71. Next, calcium score is more than 2000. So according to the scale, to implant the balloon expandable Edwards Sapien Ultra valve, were exactly nominal with a 23 mm Sapien Ultra you can see on the screen. Next. So that is what we wanted to do. Of course, we check the distance between the annulus and the ostia, which is 15 for the left, 12 for the right. It's a left dominant vessel, so it's very good. Next. The working view is LO 6.0 caudal. It's very good. It's for the coplanar view. Next. As was said, but here, of course, CT scan is mandatory to really measure the diameter from puncture site to the aorta and to see if there's a calcification or tortuosity. Here it's really perfect, so we decided to go the right groin. Next. Here again, you have the cross section measurements, which are perfect. Next. So the strategy is to implant Ultra Sapien 23 mm in diameter at the nominal diameter using right femoral artery access on local anesthesia with precaution with two conlight, two prostiles, 45 introducer, no predilatation. So far, what we have done, Christophe Tron has placed la salle. Christophe Tron has placed a radial introducer in the left radial artery with the pigtail, and we did aortograms with this pigtail. And from the right groin, we did an echo-guided puncture. We checked, and we'll show you just in a few minutes that we will position the pump. We have punctured the vessel above the bifurcation, which is very important. And Christophe has inserted the first slide, and now we implant the second one. So maybe we'll show you the angio first. Just to show you the aortogram. You will see on the screen, you can see that the valve is calcified, the sinuses are not narrow, the distance is high, and we'll show you where was done the puncture side. You see, we do an injection with the 4 trench, which is the first introducer we place. It's very small, so in case the puncture is not adequate, we can puncture again. And we do an injection of a small amount of contrast in the areola projection to be sure that we can isolate the bifurcation for the puncture side. It's very important because you make sure that you are at the right level, and also at the end, in case you have a vascular complication, you know where you have to implant the cover stent. So we do that systematically. And now we will go back to the hands and we place the second prostile. So we will pull back the first one, which was placed at 10 clock position. So Christophe is pulling it out. We have the wire in place, of course, and we'll introduce the second prostile. You know that we have different ways of using closure devices. It can be 2 prostiles, it can be 1 prostile at the beginning and one underseat at the end. Alors, je peux avoir l'enjeu en même temps. Here, en même temps. So the wire is well in place. So we will, I advance the prostile up to the exit hole of the wire. So Christophe is pulling back the wire. I advance the prostile up to the back flow. You see here, it will be here.
At the 2 o'clock position.
So I move to the 2 o'clock position.
She pulled on the lever, she pulled the device, and then she pressed on the plunger, removed the needles, and we cut the 2 threads. She pulled back the lever, pulled the device, take the CHU, and now we are going to insert again the guide wire.
So we put the thread on the side. We don't use it until the end. I reintroduce the wire in the small hole, so we have the access in the vessel. The hole is not very large. So far we have not given heparin. We wait until the sheath is placed. So I advance the wire quite high. Christophe will pull back the prostyle, which is now totally in place. So we are pleased with this pre-closure step. We advance the dilator of the 14 French introducer. In fact, it's not absolutely mandatory to use it as a dilator. But why do we use it? Because we prefer to exchange the wire, placing an extra stiff wire instead of a regular 0.035 wire. So Christophe will pull back the conventional 0.035 and will advance the wire we like to use, which is an 0.035 long, 2 meters 60 centimeter, extra stiff hook wire. So the tip is very soft, not to damage the apex of the ventricle, and the body is stiff enough to navigate from the entry side to the aorta. So I advance it and I position it quite high. Christophe will pull back the dilator, and we will advance the 14 French ischies, which is ischies because it will increase in diameter once we will introduce the delivery catheter. So the patient is doing very well. She's on local anesthesia. We did mild sedation because it was a little long for her to wait. We have to place the sheath. Est-ce qu'il faut mettre une main, s'il vous plaît? Okay. So Christophe is just maintaining pressure on the wire. I am advancing the sheath. There is absolutely no problem. You see it's in place. It's in place. So now I will pull back the dilator of the 14 sheath and will give heparin. So we'll give 70 units of heparin per kilogram, and we will reverse half of the dose at the end of the procedure before pulling back the introducer. So here we have the introducer in place. We will connect it to infusion line to have continuous pressure.
It's important to flush
yes.
sheath.
Very important to avoid any clot in the sheath, which could move, in fact, towards the carotids during a progression of the procedure. So here we are fine. We can, the pigtail is in the right position. So now it's time to cross the aortic valve. And you know that Alain Cribier had a technique. We learned, all of us learned, and he learned to teach it all over the world. It's to use an Class 2 left catheter, which is advanced over the wire in the LAO projection. So we move to LAO. We advance it over the wire. We check the wire has to be. Just wait, Christophe, because it goes to the supra, to the. Okay, can you just pull the wire? Okay, good. So we are in LAO. I advance the unplats. It's an L2. And I exchange the wire. Once I need to crown the valve, and we use a straight, regular 0.035 LM35 wire, which has a soft tip on one side and a stiffer tip on the other side. So of course I use the soft tip. I place my en-place catheter, as you see, at the upper part of the calcific aortic valve. With my left hand, I hold the en-place, and I will do a clockwise rotation and a slight pullback. At the same time, I will advance the straight wire and try to cross at one point. If I don't cross the first time, I go back to the upper part and I do the maneuver again. Sometimes it can be necessary to have a en-place one catheter, left catheter. Do it again. We gave the heparin, so it's okay. So you try to do not miss the hole, but you don't try by figuring out where is the hole. You just do the maneuver. So I have to do it again.
Yeah, it's strange, but of course.
So I have to move to LAO because we don't want to create any damage to the left ventricle. So you move to LAO. We take a gradient, but we know it from echo. It's just for us and to show you. Okay, we take a gradient. The stenosis is very tight. During this time, the nurse, I have not introduced the nurse in Solange. Vous pouvez montrer le personnel, s'il vous plaît. So we have, in the lab, we have two nurses. So we have Gaëtan, who is the nurse, and he was there for the first case. We have Virginie, who is the other nurse, who is dedicated to crimping, and we have Odile, who is the head nurse. So we have three people. We have also the echo machine, which is in the room. It is very important. It was used for the echographic, the echo-guided puncture, but even we need to have echo in case anything happens. You need immediately to be able to do an echo to see if the patient complains of something, or if you have blood pressure, you can do immediately an echo. So now we will re-advance the extra stiff wire. I will reshape it, as was also shown by Alain Dubier. I will reshape it to have a curve, a soft curve in the left ventricle. You see?
The gradient is 72 millimeters of mercury, so it's very severe aortic stenosis.
Yeah, very severe. So I go back to endoscopy, s'il vous plaît. So I will advance the wire, and we need to have a good position in the left ventricle. So Christophe will try to get it done. It's important to have a good, sometimes we need to reintroduce a pigtail. Okay, great. This is the position you need to get. So Christophe is pulling back the en-place catheter. We will get prepared to do the rapid pacing on the lead, and Christophe will explain you how does it work.
So Helene is going to place the needle just near the sheath, and we are going to place a crocodile clamp to do the pacing, and another crocodile clamp will be placed over the guide wire. But for pacing via the left ventricular wire, we need to place a catheter on the guide wire in order to make an isolation. Otherwise, you cannot pace. So Virginie is advancing the valve.
Each time we change our gloves before valve insertion, because you know it's a bioprosthesis. We don't want to add any risk of endocarditis in the future, even though we know that the risk of endocarditis in the future is equivalent to that after surgical bioprosthesis. But we pay a lot of attention to that. It's also important to be quite fast, not lose time, because each time you take time, you increase the risk of infection. So Christophe will show you the device.
So we check that the skirt of the valve is on the distal part, and we place the nose cone, which is yellow, on the guide wire.
Ne montrez pas le visage de la dame, s'il vous plaît, juste. So we are introducing. Alors, on peut voir les mains. Now we are at the entrance of the 14th French introducer, and I will advance the catheter with the loader. And each time also we have to pay attention to the guide wire in the LV. Si on peut avoir l'enjeu en même temps, les deux. Okay, because we don't want to be ejected from the left ventricle. So I am holding with my left hand the introducer and advancing the delivery catheter, which advances very easily. And I have to exit from the sheath. I will pull back the loader. There is a loader which is placed at when I introduce the delivery system in the sheath. It's better to remove it because sometimes when patients are tall, the catheter is too short. So Christophe will do with the alignment.
So first we give a small cranial angulation to be perpendicular to the stent, and then I pull on the catheter. It's very important to check the position of the guide wire, and then I rotate counterclockwise the small distal wheel.
You see, it's the proximal part of the delivery catheter. So now we are in place, we are aligned, meaning we have the balloon inside the stent, and when we will be in the native valve, when we will inflate, the valve will expand. So we move to LAO to follow the aortic arch using the flex property of the catheter. So you see, we have to move slowly, and there is a lot of flexibility with this catheter. And now we go to the implantation projection, and I connect also the proximal part of the wire to the crocodile clamp. Now we're ready, and the pacing should work. Of course, we check the pacing, so we can check it now. Est-ce qu'on peut montrer l'électro, s'il vous plaît? And I will ask the nurse to do the pacing at 180. Vas-y. Stop. You see the pacing works very well. It's immediate and the recovery is immediate. So this is what is important. So now we are in the projection view. So we'll cross the valve. So
I pull a little on the guide wire.
You see, it crosses very easily, and this page, there was no predilatation, remember. And Christophe will pull back the delivery catheter and now we have a pretty good position. I think we can go a little wider. We have the position of the pigtail, which indicates the depth of the aortic sinus. And usually the marker has to be at the level or just above. And we do it on rapid pacing because rapid pacing will be done for valve positioning. So we do it at the same time. So 180. Stop pacing. So
it could be a little
it could be a
deeper.
little deeper, yes. So I advance it a little. Okay, we do it for rapid pacing again. Rapid pacing. Injection. Stop pacing. I think it's good. It could be a little higher, in fact. So I think we will pull it back a little. Because why do we do that? It's just to, okay, so now we are ready. I will pull back